we proceed with that. How many of you have the chance to anesthetize a patient with a pacemaker coming for surgery? Did any one of you have a chance to have a patient come with a pacemaker coming for any surgery?
Yes, sir.
Yes. So you should have this pacemaker and ICD, you should have, I think it can be divided into two parts. One is the basic knowledge about pacemaker and ICD, that is as a medical person. The second is the anesthetic implications or the concerns that you should know when a person with ICD or a pacemaker comes for a surgery. Okay? So first of all, let us have some idea about the pacemaker. What is a pacemaker?
It is the device intracardial
that delivers the direct electrical stimulation.
Is a device
that delivers
provide electrical stimulus
to
stimulate the heart.
To stimulate the heart. So why do you need the pacemaker? What is the necessity to have a pacemaker?
So that myocardium will depolarize and cause contraction.
When the heart is not able to generate its own contractility, which is the pacemaker, natural pacemaker of the heart?
SA node.
SA node. Okay. So SA node, how does it generate this contractility? In what way the action potential of SA node is different from the action potential of myocytes? How many phases of action potential are there in a normal action potential of any muscle? Whether a skeletal muscle or a cardiac muscle. How many phases are there? Four phases are there. For the SA node or the pacemaker cells, are there 4 phases or less phases?
Less.
It is very less phases. And does it require any stimulus to initiate the action potential? The pacemaker cells?
No, sir.
No, sir.
No. So what is the name for that? When it
Automaticity.
Automaticity. Okay. So automatically it passes depolarization and repolarization at a rhythmic interval, so that there is an electrical potential generated to pass it on to the nerves through the conduction system, and then generate an action potential in the myocytes to make them contract. Okay? That is the whole simplified form of the conduction of the electrical potential in the heart. So the action potential is generated at the SA node. How does it traverse to make the heart contract? What is the conduction pathway?
SA node to AB node, AB node to
SA node to AV node, does it jump like that, or there are
AV nodal delay? That is AV node.
From SA node, does it directly come only into the AV node? How do the atria contract?
Three pathways are there.
There are bundles going to the atria first, isn't it?
Yes,
Much bundle and the atrial bundle. There are 3 bundles which supply the atrial muscles, and there is a nerve fiber going to the AV node also. And from the AV node, how does it traverse?
Bundle
Of this, which divides into right and left, and finally the Purkinje system. Okay? So this is the entire conduction system of the heart. And there can be pathologies or defects starting from the pacemaker area SA node, or at the AV node, or at the conduction system, which will interfere with the normal sequential contraction. So how is the sequential contraction of atria and ventricle maintained in normal physiology? The first atria have to contract and expel all the blood that they store into the ventricle. Then ventricle has to contract and pump out the blood into the pulmonary and systemic circulation. This is the basic method of cardiac output. So how does it happen that when the atria contract, the ventricles relax to receive the blood. And when the ventricles contract, the atria relax to receive the blood from the various parts of the body. So how is this sequential contraction of atria followed by ventricular contraction and relaxation take place? What is the main important thing to do this?
AV nodal delay.
Very good. That is one. But intrinsically, once there is a depolarization and there is suddenly some other stimulus is coming, as the depolarization is taking place, can that stimulus stimulate the cells?
Yes, sir.
Yes. What is the period when the cell cannot be stimulated during a depolarization called? See, there is a resting potential, then it changes to threshold potential. Then once it crosses the threshold potential, there is a stimulus potential which opens the channels for the electrolytes to pass on and produce a depolarization, which means negativity changes into positivity inside the cell, and then action potential is transmitted, and then it is brought back to the original resting membrane potential by exclusion of sodium and re-influx of potassium inside the cell. This is the basic thing that all of us know, isn't it? So this depolarization, when it is occurring, if there is a second stimulus, will there be the same change happening? That is the very important point all of us know. That is called the absolute refractory period. Okay? So once a single stimulus is stimulating the myocyte or your pacemaker cell, and when these changes are taking place, if a subsequent stimulus comes, during the initial phase, until the repolarization starts, it cannot be stimulated. The channels cannot be opened again to allow the ions to move across. So that is called the absolute refractory phase. And during the repolarization phase, when the sodium is extruded out and then potassium tries to come back, there is called a relative refractory phase. Okay, that time again, when you have a small stimulus, that can again reproduce or institute a depolarization. Okay? So this absolute refractory phase and the relative refractory phase are the two important things which prevent the occurring of a second stimulus producing contraction and damaging this sequential contractions of atria and ventricle. Okay? So this, apart from the atrioventricular delay, this refractory period is a very important period during which the cell cannot be stimulated. Okay? So the same way, your pacemaker also should function. Why that is important? Because the heart may still have some intrinsic contractility. Not that your heart, which requires a pacemaker, has become totally standstill. It may contract independently in total heart block. Still, the atria may contract at one particular rate and ventricles may contract at another particular rate because all the stimuli is not conducted. On the contrary, if it is a SA node pathology, the generation of stimulus itself will be low and the rate may be very low, but still the heart is contracting. Okay? So when you apply a pacemaker to a heart which requires stimulation, it should not collide with the intrinsic activity of the heart, which will cause a jeopardy, and that will cause what is called dysynchronization. So instead of atria contracting and ventricle relaxing, both may contract at the same time, resulting in no blood flow. Okay? And what is the name for that condition when they are not synchronously contracting? Like atria to contract first, ventricle relax, receive the blood, then ventricle contract, atria relax. So if this sequence is not happening and both atria and ventricle contract at the same time, what is that condition called? Any idea? What is the one complication normally you see when a patient goes on dialysis initially? When you can remove excess of fluid or cause excess electrolyte imbalance. What is the name?
Equilibrium syndrome. Dyselectrolyte.
Disequilibrium. Dialysis disequilibrium syndrome. Similarly, this sort of synchronization syndrome is called pacemaker syndrome. Okay, so the pacemaker syndrome should not happen when you institute a pacemaker, and for that to prevent that pacemaker syndrome, there should always be a sequential contraction of atria and ventricle. Okay, and that is achieved in the pacemaker by incorporating this refractory period concept when the heart cannot be stimulated. So, for example, let me put it this way. You have a SA node defect and the intrinsic contracting rate of the heart is only about 35. That is not adequate to produce enough cardiac output. So, you implant a pacemaker in that patient and you set the rate at 70, which is the normal rate. And when the pacemaker is delivering a particular stimulus and your native heart also is having a contraction at that time, both should not clash with each other, isn't it? So what will happen? The pacemaker, if there is an intrinsic contractility of the heart muscle, it will withhold its discharge of current and will not clash with the native heart contraction. And that is the mechanism by which this the dysynchronization or the lack of synchronization is avoided in pacemaker. And that is what you are going to remember in the pacing code that you are going to use. Okay. So with this particular introduction, I will just go on to share the slides so that you can understand the concept more easily. This is also will be a question answer type. And if you know the answers, you can answer that. Okay. So what are the types of, what is the expansion for CIEDs?
Cardiac implantable
Electronic devices.
Electric devices.
Or electrical devices, whatever you want to call. Very good. Cardiac implantable electrical devices or electronic devices. So what are the different types of them? What is a different type? The question is wrongly worded. There are two things, pacemaker and ICD. Okay, both are not same. Do you know that? All of you know that? Pacemaker and implantable cardiac defibrillator, both are not the same. Please remember that. Okay. So cardiac implantable electronic devices are cardiac pacemaker and implantable cardiac defibrillator. So the differences between these two important things you have to be primarily learned is pacemaker is primarily used to treat bradycardia. Okay? Whereas this defibrillator is implanted to treat life-threatening ventricular tachycardia or ventricular fibrillation. And pacemaker delivers low-level electric pulses, whereas implantable defibrillator delivers a shock just like your external defibrillator which you use, but not in that huge strength, or the current strength is much lower because it is directly acting on the heart like an internal defibrillator. So but the current strength is much more compared to the pacemaker. And pacemaker is used to increase heart rate and rhythm, and whereas this one is used to treat arrhythmias. And the indication for a pacemaker are SA node dysfunction is the primary source for stimulating the heart, or advanced second degree AV block or third degree AV block. So these are the three main indications for implanting a pacemaker into the patient. On the contrary, it is ICDs are indicated in sustained ventricular arrhythmias like or ventricular dysfunction or earlier cardiac arrest which is likely to recur. Okay, that is the most important reason for planting the ICD. So, what are the types of pacemaker you have? Any idea?
Temporary,
Transvenous,
permanent,
transcutaneous,
It can be
temporary or
Per-
permanent pacemaker.
permanent and temporary. Very good. So, what are the types of permanent or temporary pacemaker?
transcutaneous, transvenous.
Transvenous,
Epicardial.
transcutaneous. So, pacemakers can be temporary pacemaker or permanent pacemaker. Any idea what are the types of temporary pacemakers? One is transvenous, another is transcutaneous, then any other?
Subcutaneous.
Can be transvenous, transcutaneous, or epicardial. Okay? So, what are the indications for permanent pacemaker? Already we have given here, but some more detailed indications are SA node dysfunction or what is called sixth sinus syndrome, tachybradyarrhythmias, AV block, third degree block, chronic bifascicular block, RBB, etc. So all this has been given here in a very simple form. So remember at least these three: SA node dysfunction, second degree or third degree heart block, or long QT syndrome, syncope without electrocardiogram diagnosis, cardiomyopathy refractory to other treatment. So these are all the indications for permanent pacemaker implantation. What are the components of a pacemaker?
Leads,
Leads, electrode.
pulse generator,
First, they should be having a source of electrical delivery system. Okay, that is a generator. A current generator is there. So a pulse generator is a very important component of the pacemaker. That only delivers the current that is required, and that is passed on to the heart by leads, electrodes connected to the heart, used for sensing and pacing. And you can see this is the pulse generator here, and then the lead is implanted either in the atrium or in the ventricle, and then they are attached to the endocardium of the right atrium or the right ventricle. So it is passed through the venous system, the subclavian vein, then entering only in the right side of the heart. Sometimes you can push it through the septum into the left ventricle also. So these are the three locations where it can be usually placed. And what are the pacemaker codes? This is a very important knowledge that all of us as a medical person should have. So how is the pacemaker code classified?
First is chapter taste.
Hmm.
5 types: pacing,
Sensed the
sensing,
There are 5
response and
Very
program.
good.
tachycardia.
Last
So
is
code 1, code 2, code 3, code 4, code 5. There are 5 things. Isn't it?
yes, sir.
So how is it classified? So letter 1 is called the chamber which is paced. Letter 2 is chamber sensed. And the letter 3 is mode of response to sensing and programmability or rate modulation and multi-site pacing. Okay? So these are the 5 letters that are used in the coding. And it can be A for atrium, B for ventricle, D for dual. All of you know about that. And this is the figured or inhibited thing. So these 3 are the common letters which are used for using the coding system. And 4 and 5 are very rarely used. Okay? So these 3, what they mean, we should be having a clear idea. So what do you mean by letter 1, which is chamber paced? What is the meaning
Is
of
this a
that?
single pacing or the double? Dual pacing?
This is the one which is being stimulated. Okay, the current is delivered either to the atrium or to the ventricle on the right side, or to both the atrium and ventricle, depending upon the pathology. And the muscle is stimulated when it is delivered. By being said, it is paced. And what is the meaning of chamber sensed?
Cardiac activity, how it is.
Cardiac activity. the intrinsic activity, mainly the intrinsic activity, because you don't need to, of course, you need to see whether your stimulus is working and whether the cardiac muscle is contracting for that. But more than that, this sensing is important for the intrinsic contractility of the heart. Okay. So based on that only, the mode of response to sensing will happen. So either it can be triggering more contraction, or it can inhibit, or it can do both. So this is the response. So these are the three letters which will be usually used for uh, indicating the mode of action of the pacemakers. And these other two things are usually rate modulation and multi-site pacing. You know what is multi-site pacing? That is, instead of a single pacing, like in the atrium alone, if you have both atrium and ventricle and also left ventricle, then it is called multi-site pacing. So it may be multi-site pacing, and but these three only commonly used to indicate the mode of action of the pacemaker. So I'll just give you some examples of these modes using these three first letters, and you try whether you can say what is the indication for their use. Supposing you say AAI mode, what does it mean? It is
The pacemaker
explain
in
that.
the atrium, sir. First,
It is facing the atrium.
atrium.
It is sensing the
Sensing the
atrium,
atrium.
And it is
And inhibiting the
inhibited mode.
okay, this is the simple meaning of this AAI. So what will be the indication for this particular mode? In which condition you have to institute this mode? Because once a cardiologist plans to implant a pacemaker, he should decide what mode of stimulus should be implanted in that person. So when you have to pace and stimulate or sense A, that means the problem is with which particular level of conduction.
Any SA node?
It is SA node itself is not working. Okay, so normal AV conduction is not there with symptomatic sinus bradycardia. Okay, so that is the indication for that. Similarly, when you have VVI mode, that is ventricle is spaced, ventricle is sensed, and again there is an inhibitory mode. So what does this mean? Does it mean atrium is normal and ventricle is not functioning properly?
Any left bundle branch block, sir.
See, atrial fibrillation and slow ventricular response. So in this condition, you stimulate more the ventricle. Okay? So if there is no adequate response in the ventricle after atrial fibrillation, you put the patient on ventricular stimulation. And it is a dual mode, DD, that is both atria and ventricular paced, both are sensed, and both inhibitory and triggering is there. So in which condition you will use this?
Third degree heart block and second degree heart block.
Complete heart block and normal sinus node function. Okay? So in this condition, you use this particular mode of stimulation. Very good. And if it is AOO, BOO, or DOO, what is this?
SA node dysfunction, sir.
SA node dysfunction. What is this whole thing called? If there is no pace sensing, there is no response to sensing.
It is asynchronous mode.
It's called asynchronous, used for temporary pacing application, and electromechanical interference is present. Yeah, this is also called the asynchronous mode. The other name for AOO or VOO or DOO is asynchronous mode. It's used mainly for temporary pacing application or when there is a conduction interference. Okay? And then the various modes of pacing, they can be asynchronous, single chamber demand pacing, dual chamber atrioventricular sequential demand pacing, and rate adaptive pacemaker. These are the four basic modes of pacing: asynchronous, single chamber, dual chamber, and rate adaptive pacemakers. Okay? And describe the mode of pacing, advantages and disadvantages of each mode. That is another thing which we all have to know. One is the asynchronous mode, which we just now saw, is the pace at the preset level is independent of the inherent contraction of the heart. So whatever be the heart rate, the asynchronous mode will deliver a particular preset mode without interfering with the native contraction or the inherent contraction. That is where I told you the refractory period system will work out here, and your computer in the pacemaker will sense whenever there is a native contraction or intrinsic contraction happening, it will withhold. But ultimately, just like your SIMV in ventilation, it will deliver a preset rate and maintain the cardiac output. So that is about asynchronous mode. And this is described in the AOO, DOO, and dual chamber DOO. And it is a competition and fear for the potential complications. As I told, if it is not able to sense the native contraction or intrinsic contraction, then it will clash with the native contraction. And if it is not properly programmed, then it may potential complication of producing a ventricular fibrillation and normal heart rate reappears. So that is the only thing, but majority of the time the program will be so nicely sensed by the leads, and they will be able to adjust the rate and deliver the set rate properly. So an impulse is generated at the same time on patient's own. Sometimes there can be what is called the R on T phenomena. That is the only risk of this particular mode of stimulation. The second mode, which is called the single chamber demand pacing mode, paces at a preset rate only when the spontaneous heart rate drops below the preset rate. So this is much more safer method, and this is also called the demand pacing. So when the rate goes to below a particular level, which is set in that machine, you can program it in that way, and automatically the pulse generator will deliver a current and maintain the rate. So the ventricular inhibited pacer. So this is called VVI, is the most popular type, and it is suppressed by normal electrical activity of patient's own QRS complex. That is, whenever the myocyte contracts, it will withhold its stimulus and adjust it in the ventricle. So this is it is like your SIMD. Whereas this is more like a controlled ventilation, okay, where you deliver a particular breath at a particular rate. Analogy you will be able to understand easily. So this is a sequential adjusted stimulation. And the third method of dual chamber atrioventricular sequential pacing, this requires two pacemaker leads, one in the right atrium and one in the right ventricle. And the atrium is stimulated to contract first, and after an adjustable PR interval, the ventricle is stimulated to contract. So it is just like a normal sequential contraction from the say node to the AV node that is achieved by the dual chamber method. And the coding for that is DDD. That is, both the chambers are paced, both the chambers are sensed, and both inhibition and triggering is possible. So the dual chamber pacemakers provide the benefits of maintaining atrioventricular synchronous contraction. And the last method is the rate adaptive pacemaker, which is considered for patients who do not have an appropriate heart rate response. It's called chronotropic incompetence. For example, when you do exercise, your heart rate has to naturally go up to maintain the cardiac output. So in a patient who is not able to generate adequate heart rate, you have to implant this, what is called the rate adaptive pacemaker. It may be due to drug treatment by negatively chronotropic like heavy beta blocker usage, or conditions like sick sinus syndrome. In this condition, the indication is for rate adaptive pacemaker. Now, how to choose the mode. How does the cardiologist? Of course, these are all done by cardiologists, so that is the reason why, as anesthesiologists, we have some confusion or we don't have a proper concept of that. So, how do the cardiologists choose the pacing mode? It depends on the particular pathology. The patient has SA node disease, no disease of the atrioventricular node or bundle of his, and the atrial pacemaker could be placed. Okay, so only isolated SA node diseases, you choose atrial pacemaker. And if the disease is on the AV node or conduction, then dual chamber system is required. If the patient has sinus node disease, AV node disease, and lower conduction system, that means the entire conduction system is damaged, whose heart do not respond to an increase in metabolic demand, placement of rate adaptive pacing system is indicated. So earlier we saw what are the 4 modes of pacing, and now we are seeing the clinical implication or indications for them. And the patient with episodes of symptomatic bradycardia due to SA node or AV node disease, you need a single chamber ventricular pacemaker. It's a BVI. And neurocardiogenic syncope due to carotid sinus hypersensitivity or vasovagal syncope and hypertrophic cardiomyopathy, you need what is called the dual chamber pacemakers. And electromechanical asynchronization or intraventricular conduction block can be treated by biatrial or biventricular pacing. And what are the features of ICD? So far we saw all the features of pacemaker, but in what way the ICD is different? The features of ICD are: it responds to dysrhythmia by delivering an internal electric shock within 15 seconds as soon as it responds. And how does the ICD able to recognize that there is a dysrhythmia? Can you just logically think and answer that question? How is the ICD implanted into a patient able to recognize that there is a dysrhythmia in the patient? This is internal defibrillation. ICD can produce anti-tachycardia or anti-bradycardia pacing and also synchronized cardioversion. How it works is it has a detailed diagnostic data, and it is stored in the memory of the device and can be retrieved for analysis. These are all, of course, the features. So how does it function? It measures the cardiac RR interval and then categorizes the rate as normal, too fast, which has very short RR interval, or too slow. So it is able to recognize this particular the interval between the two R leads and detects a sufficient number of short RR intervals within a period of time. Then it will declare that as a tachycardia episode. And the integral computer will decide between the anti-tachycardia pacing and shock based on its programmed algorithm. So that much of advancement is there in the computer integrated pulse generator of the ICD, which is different from the pacemaker. And the generic code which we use for pacemaker, does it apply to the ICD?
No, sir.
No, it won't apply because its main function is anti-tachycardia and shocking. So the coding system, even though the lettering are the same, instead of pacing, it is the shock applied to the chambers, anti-tachycardia pacing chamber, tachycardia detection, and the anti-bradycardia pacing chamber. So the coding is each different, even though we use the same A, V, D, etc. The nature of function is different. So instead of pacing, it is shock. Instead of sensing, it is anti-tachycardia, and it is tachycardia detection from the electrocardiogram or hemodynamic, and the anti-bradycardia pacing in cases of bradycardia is also there. So it can tackle both tachy and bradycardias, and in tachycardia it can sense whether it is simple ventricular tachycardia or ventricular fibrillation to institute the therapy of anti-tachycardia measure or a mild defibrillation to convert fibrillation into sinus rhythm. So this is the main difference between the pacemaker and ICD. Okay, so the coding is completely different based on the function, even though the lettering is the same. Now, what are the indications for insertion of ICD? Though initially ICDs were indicated for hemodynamically significant ventricular tachycardia or ventricular fibrillation, now they have added more indications. In the 2006, cardiac arrest, which resulted in which was caused by ventricular tachycardia or fibrillation, and not from a transient or a reversible cause. That means there is a possibility that VT and VF can recur in this patient again and again. So the 5 causes which we normally read for cardiac arrest, there are 5 T's and 5 H's, that is a reversible condition. That is a single event. For that we don't put an ICD. Whereas a patient who is likely to suffer from recurrent VT and VF, in that patient only we have to insert an ICD. That is the first and foremost indication. Second is on sustained VT with a structural heart disease. To find out a structural heart disease, we have to can stimulate that patient. And syncope of undetermined origin, clinically relevant, hemodynamically significant sustained VT, including electrophysiology study. And ischemic cardiomyopathy patient, an EF of less than 30% with a recent myocardial infarction, that is another indication. Ischemic or non-ischemic dilated cardiomyopathy is also another indication for ICD. And there's a syndrome called Brugada syndrome, where it will be in the ECG, you see a right bundle branch block with a ST segment elevation in chest lead V1 to V3. So whenever you see RBB, which is a normal innocuous condition which is ignored or accepted for surgery, always make it a point to look at V1 to V3. Rarely you may find ST segment elevation in this, which then will become a Brugada syndrome, where sudden death in young persons is very, very common because of this. So whenever you read an ECG with an RBB, don't forget to look at the leads V1 to V3 for any ST segment elevation also. And once in a blue moon, you can definitely find this change in the ECG, and you will be definitely rewarded by identifying this patient who can develop a sudden VT or VF and die. And arrhythmogenic right ventricular dysplasia is another condition. High risk patient with QT syndrome, and defined as those aborted cardiac arrest or recurrent cardiac events like syncope, toxic response, and despite conventional therapy with beta blockers, then the patients will have a prolonged QT interval like more than 500 milliseconds. So these are all the things which may be subtly present in the ECG, which are missed, and the reasons for sudden death after surgery in a young patient. This is one of the things which is being missed in the preoperative assessment. So you have to be careful with these two, number 6 and number 8 in ECG. You don't take everything for granted that because the patient is young, nothing can go wrong. Right? So then hypertrophic obstructive cardiomyopathy is another condition for implanting ICD. Now coming to, after knowing the basics of this particular pacemaker and ICD, now comes the main question of how to manage a patient coming for emergent surgery. Supposing there is no time, you have identified there is a problem with the conduction system. Either it may be in the SA node or AV node or this. And but the patient has come for an emergency surgery. What to do in that situation?
To know the pacing mode.
See, patient is needing an emergency surgery. You can't postpone the surgery, but the heart looks like he needs a pacing. So, what type of pacemaker you can or pacing you can do? Is the reason why first question is what are the types of pacemakers? Temporary and permanent. So there is no time to implant a permanent pacemaker in such situation. So you go for temporary pacing.
Temporary.
For emergency surgery, where pacing is indicated, but there is insufficient time, you can put the pacing wires, the patient external transcutaneous pacing pads. Okay, so that is how you try to manage the situation by transcutaneous. Earlier, we were using transvenous pacing very commonly, but this is less cumbersome and much more easier for anyone to do that. So, where do you place these pads to stimulate the heart in case it is necessary? The transcutaneous pacing mode. Where are the pads attached? Where do you attach the pads for defibrillation?
Anterior system,
Anterior and lateral, below the right clavicle and the apical regions, isn't it? So this is the position where you place that. It can be anteroposterior, where on the left side, close to the apical region, you apply one pad, and similarly on the same left side back, you put it on the back also. This is called anteroposterior placement. And the other one is called the anterolateral. Just like your defibrillation, you can put it on the right side below clavicle in the apical region on the left side. So this is the lateral, the anterolateral placement. This is anteroposterior placement of pads, which you should know in case of emergency. So how is transvenous pacing done? This is transcutaneous. So how do you do the transvenous pacing? Which vein you choose?
ICV.
You can choose subclavian, IJV, or even cubital. Okay, so the veins, the catheter is inserted into the vein, either internal jugular or subclavian or vein in the cubital fossa, and the catheter is advanced through the vein into the right atrium or right ventricle. Okay, so that is the lead. Catheter means it's a lead, and you will have the pulse generator outside. Okay. The pacing lead is connected to the external pacing generator, which delivers the electrical pulses to stimulate the heart and relate it to the. So this is the picture of the transvenous pacemaker. Okay, so it is just like your PA catheter with a balloon, and the tip has got the electrical thing to stimulate. So through either IJV or a subclavian or cubital, you pass this into the heart and it goes and settles down at the ventricular level, and you have the electrode plug through which you can deliver the current to the heart. Okay? So remember these two methods of temporary pacing in case of emergency. That is the answer that you have to give in the exam if they ask you. What is the bipolar and unipolar pacing? That is again a different type of putting the leads in that. So the pacemaker is again outside, and you can put it in the both the atrium and ventricle, or it can be this is epicardial placement. This is transvenous pacing, and this is epicardial unit. All these things are more invasive. So what are the advantages and disadvantages of this unipolar and bipolar? Less impedance is required in bipolar, more impedance in unipolar, and less current is used in bipolar and more current is required. Requires two cardiac leads, only one lead in unipolar, and less electrical interference from high potentials, and less chance of diaphragmatic pacing. Whereas by unipolar, you can stimulate the diaphragm also, and with this the tiny badly visible space in bipolar, and the ECG will show a large spike when you take a unipolar. Sometimes this is mainly given to show you how the ECG change can happen. And of late, people have invented that putting this lead wires inside is quite cumbersome. So you have what is called the leadless pacemaker. There are the advantages and disadvantages of that are it is a small one-piece device implanted directly into the heart, either into the atrium or the ventricle to regulate heartbeat. It is designated to eliminate the need for traditional pacemakers with external leads and association. And it is quite small and less invasive compared to the catheter-based procedure. And it's a catheter-based procedure. So this is the size of the leadless pacemaker. Okay? So it is inserted into the heart just like your transvenous spacer, but inserted permanently into the muscle itself so that it can activate without any problem. So the need for keeping a pulse generator and then trying to simulate all these things are not there. And it can be a single chamber or a dual chamber placement. And the indications for this are patients who have undergone ablative surgery for any arrhythmias, they do better with this particular leadless thing. And patients who develop vasovagal syncope, nowadays there is an indication for that. And patients who are hemodialysis, who require pacemaker, they prefer this leadless pacemaker because the electromotive interference is much less in that. And some congenital heart diseases are also the indications for this particular equipment. Now, how do you evaluate a patient with pacemaker before surgery? This is a very common question that the examiners will be asking you, and if the theory question is asked, you have to write all this. So, what are the steps that you have to follow when a patient with a pacemaker comes for pre-anesthetic assessment? How do you plan the anesthesia? And how do you avoid all the problems that can happen to the patient?
Should I ask about indication placement?
First is interrogation. Okay, routine systemic workup and the particular attention to cardiovascular status. Then you must find out the presence and location of the cardiac implantable electronic device and what is the reason for its insertion. That is a very important diagnosis that you should know. Whether it is thick sinus syndrome or whether it is a AV block or whether it is a cardiomyopathy. So, on the earlier slide, we saw what are all the various pathological indications where you require this insertion. So, we must know that particular region and look for the scars for the chest and abdomen where the pulse generator has been implanted. And take a chest X-ray and confirm the location of the device. What is the chest X-ray will not only confirmation of the device, what else will you see in the chest X-ray?
Pulse generator.
No, pulse generator location. That is what is I'm given here. Apart from this, what
Dual
else you have
pacing or single pacing?
Huh?
Dual pacing or
Any disconnections?
Lead, whether the lead is in continuity or not. Sometimes, the leads may get detached from the pulse generator. Your chest X-ray will show you whether the lead is properly connected to the pulse generator and it is in continuity. Okay? And what information about pacemaker should be obtained? All pacemaker patients will have a full record when it was inserted, which company pacemaker, what is the battery life. Okay, so that is called interrogation of the pacemaker. Type of device and program mode, whether device is functioning properly, whether patients dependent on the device or independent, because demand pacemakers, patients normally are able to live on their own at intrinsic contractions. And the pacemaker will only come to help when there is a need for that. On the contrary, some patients may be chronically dependent on the pacemaker rate. So, dependence should be examined and the probability of electromagnetic interference in the theater, how to minimize the risk, and obtaining manufacturer's identification card from the patient or other sources, and vendor database, pacemaker clinic records, or the cardiologist, if you can approach him and find out what is the reason he inserted the pacemaker or ICD and what are the clinical indications for that. If you can have a discussion with the cardiologist, that will be the most ideal thing. And how to check the pacemaker function before you start take up the patient. Is there any way, supposing all these things are not available for you, and you want to see whether the pacemaker is functioning normally or not, can you do any clinical tests by which you can find out whether the pacemaker is functioning normally or not? Can you reduce the heart rate? For example, a pacemaker is designed to deliver current and stimulate the heart if the heart rate goes below 40. Can you reduce the heart rate in that patient by some technique and see whether the pacemaker comes to help by delivering extra beats? What is the physiological technique by which you can reduce the heart rate? A technique starting with the word V. Valsalva. Okay, the pacemaker function should be checked where possible by pacemaker technologists and interrogation if it is available. Otherwise, slow the intrinsic heart rate by Valsalva maneuver, and functioning pacemaker will then take over the heart rate. Okay? So either carotid massage or Valsalva maneuver, you can reduce the heart rate clinically. Bilateral is one of the treatment for SVT. Whenever the supraventricular tachycardia is there, you can do bilateral carotid massage at the bifurcation to stimulate the carotid bodies. Okay, that will lower the heart rate. So the same thing you can try to find out whether the pacemaker takes over to improve the heart rate. What are the causes of device failure? One is early failure and another is a late failure. Early failure is usually because of the broken electrodes, leads which are disconnected or broken. Late is because of premature battery failure. Okay? What is the battery used in that? The AAA, AA or any specific battery used in pace generator is lithium iodide battery. Lithium iodide battery. Okay, and usually it has a life of 9 to 10 years once implanted. Okay, but sometimes it may die prematurely. So these are the two reasons for failure of the device. Then how to determine patient's dependency on the implanted device? Of course, once we check the device by reducing the heart rate, but determining the patient's dependency, that can be done by verbal history or an indication on the medical record. The patient has experienced any syncope. That's a very, very important history. And the history of successful atrioventricular nodal ablation, the reason for placing this. So sometimes they do nodal ablation, and then no evidence of spontaneous ventricular activity at all. The pacemaker function in the CIED is programmed to VVI mode, pacing mode. That means the ventricle is not acting at all. That patient will also be dependent on the pacemaker. And the ECG, which shows taking spice if the patient is dependent on the pacing function. So constantly you get a pacemaker spike. All of you would have seen ECGs with that. Before the QRS complex, there may be a pacing spike. A straight line, vertical line will go, and then the QRS will occur. That means the patient is dependent on the pacemaker. What are the concerns regarding electromechanical interference? This is the most important complication that can happen in a patient with a pacemaker or ICD coming for surgery. So, which are all the sources of EMI in the OT?
Electrocautery.
Electrocautery, most common thing. Okay, but all electrocauteries they produce
Monopolar.
unipolar. Unipolar cautery is the most important device, and other things which can generate electrical potential. So malfunction may, if the electromechanical interference is there, the problem that can happen is it can make a pacemaker function defective, or it can produce a burn to the myocardium or ventricular fibrillation, because the leads are implanted into the heart muscle. That also can be happening because of the interference. And if the pacemaker malfunction can be in the form of either inhibition of pacing, or it can automatically convert the pacing mode into asynchronous pacing, or reset to backup mode. These are the three changes that can happen. And who are the patients who have high risk to this electromechanical interference? Patients, three groups of patients are at a very high risk. One is patients who are pacemaker dependent rhythm, complete AV block, who may be severely bradycardic or systolic from electromechanical interference. So if the pacemaker has been inserted for complete AV block, we take extra precautions to avoid this electrical interference in theatre. The second group is patients with an ICD, that is patients who have been inserted with a anti-arrhythmic programmed machine to prevent VF or VP. So these patients are going for arrhythmias. The third group is pacemakers with a rate responsive function. These are four categories of pacing: asynchronous, single chamber, dual chamber, and rate adaptive function. So that rate responsive function also will be very badly affected. So three groups of patients: patients with AV block, patients with VP and VF who are having ICD, and patients who have rate responsive mode of stimulation. These are the three groups which will be very severely affected. So we have to avoid the electromechanical interference in these cases very severely. All other cases, it may be very mild. And what are the sources of EMI? A lot of things are there: electrocautery in unipolar configuration, external cardiac version or defibrillator in case suddenly the pacemaker dysfunctions. Then if you are going to use a cardioverter or a defibrillator, that will affect. Patients, if they go for ECT, patients with this pacemaker, if they go for electroconvulsive therapy, they will definitely have a problem with that. And usage of TENS. What is TENS? Expansion.
Yes.
And where is it used?
Transcutaneous electrical nerve
stimulation.
Trans-electrical nerve stimulation for pain relief. Okay, so that also is one of the chronic pain treatment where it can be affected. And if you want to do evoke potential monitoring during neurosurgical procedures, that again can produce interference with the pacemaker function. Extracorporeal shockwave lithotripsy, okay? That is another condition. And radiation, any radiation exposure, MRI, and peripheral nerve stimulation used to control or monitor nerve stimulus, neuromuscular monitoring, that also can affect. And shivering definitely can produce that. And fasciculations produced by dexamethasone usage, that also can affect. So better to avoid fasciculation, dexamethasone in patients who have this, especially these three groups of patients. We have to definitely avoid that. Then another common gray area in pacemaker is the role of magnet in patients with this posted for surgery. Do you have any idea about that? Always there is a component of this discussion is placing a magnet. Okay. What does the magnet do? Where does it actually need to be placed? On the lead or the pulse generator? It has to be placed over the pulse generator. Okay, and it is close a reed switch, and it will convert the program into asynchronous mode. That is the reason for that. So magnet correctly applied over pacemaker results in asynchronous fixed rate pacing method as a predetermined rate without rate responsiveness. Okay? So the effect of magnet is variable. Pacemaker response varies depending on the manufacturer, and pacemakers with respond to fixed rate pacing after the magnet has held over the generator. For ICDs, the magnet will inhibit the delivery of anti-tachycardia pacing in shock therapy, but have no effect on bradycardia pacing. So definitely, if the heart rate goes down, still the ICD will function, but it will be inhibiting the anti-tachycardia and shock pacing therapy. And if the magnet is used, the effect of magnet on a pacemaker or ICD should always be checked before proceeding with the surgery. And the response to the presence of magnet in both pacemakers and NCD is only temporary. So after removal of the magnet, you can revert back to the normal function after the procedure is over. And the advantage of magnet application is very simple and doesn't require any need for reprogramming. The device will automatically come back to that. Okay, so this is the magnet that is usually applied over that, and this will be the area where the pulse generator is implanted in that. It can be just kept for some time and removed, or it can be kept there permanently with a microport plaster until the procedure is over. So this gives a safety margin that even if the pacemaker malfunctions, you will still have a particular fixed rate pacing going on, so that patient will have a guaranteed cardiac output. That is the simple thing that you have to understand about the magnet. But recently they say that the magnet application is not necessary. Earlier it was made as a mandatory thing to apply the magnet and convert whatever mode is there into asynchronous mode. But now they say that the advancement of the pulse generators and the pacemakers, they automatically take care even in electromechanical interferences. So the magnet application is no more recommended. That is the current thinking that is being there. But in the exam, they may ask you about this, and that is the reason why I have given all the details here. And the intraoperative management of any patient with that proper intraoperative monitoring will require availability of you should do all the required intraoperative monitoring routinely, and you should have availability of equipment and drugs to maintain an uninterruptible system in case there is a failure of this thing. And so what are the things that you have to look in the ECG? Any specific thing in the ECG you have to look for?
Spice.
Huh? So the importance artifact filter in the ECG should be disabled. Normally, all the ECG monitors, we put them on filter to avoid the electrocardiography disturbance and other earthing disturbance from the electrical circuit. But here, because the pulse generator has to deliver its current, that has to be sensed. If you put the artifact filter, the spike that is produced by the pacemaker will not be detected. So to detect the pacing spikes, you must remove the artifact filter in the ECG monitor before you attach the monitor to this patient. The second thing is it should be kept in a diagnostic mode instead of monitoring mode, because the former has got wide frequency response, and which enables assessment of QRS morphology and more accurate ST segment analysis. So these are the two changes that you should do in the ECG monitoring when you attach it to the patient with a pacemaker. And with regard to pulse oximetry and the other standard monitors should be definitely in place. And what drugs and equipment you should keep ready in these cases is that a transcutaneous external pacing and DC defibrillator should be available in case there is a tachycardia and arrest. And the usual drugs for resuscitation should be readily available whenever you take up a patient with a CIED. Avoid nitrous oxide if the pulse generator has been recently implanted, say within say 3 to 4 days. Then avoid nitrous oxide because it can accumulate in the pocket that is created in the pectoral region for implanting that generator, which may lead to the lead disconnection. The anodal contact and pacing system malfunction can happen. Avoid hyperventilation. The alkalosis could acutely change the serum potassium concentration that will alter the cardiac threshold for pacemakers. And succinyl choline can increase the stimulation threshold due to acute increase in serum potassium, and also muscle fasciculation can inhibit the pacemaker. So the two reasons why you should avoid succinylcholine is it will cause hyperkalemia, which will interfere with the cardiac activity. And the second is muscle fasciculation, which will inhibit the pacemaker. And avoid etomidate and ketamine also because they can produce myoclonic movements, which will again interfere with the pacemaker. Exercise caution while inserting a central line, as this may dislodge the lead wires. And for patients with bradycardia, high dose anesthetic that can exacerbate bradycardia, for example, using dexmedetomidine or fentanyl, that also can interfere with the pacing and cause problems. And patients with long QT syndrome, where the indication for CPD, drugs which will prolong the QT like haloperidol, methadone, high dose potent volatile inhalation agents, they all can lead to what is called polymorphic ventricular tachycardia. So avoid these drugs in that. Now coming to the anesthetic technique, can be GA, central neuraxial blockade or nerve block, depending upon the surgery. For example, any upper limb surgery, you can manage it with a supraclavicular or interscalene block. Lower part of the abdomen and lower limb, you can manage with a central neuraxial blockade. So that the indication is there. Proper pre-op evaluation, preparation by programming the CIED, stop monitoring, preparedness to manage pacemaker complications. They are all the same for, these are all the standard answers you should give for any type of anesthesia, whether it is GA, CNG or no block. But avoid high level central neuraxial blockade, which can cause hypotension and bradycardia, which may affect the function of the pacemaker. So any block below T10 level is quite agreeable. So if you want any block which is above that level, preferably going with a combined spinal epidural, where you can give a small volume and achieve a level first, and then without much hypertension and bradycardia, you can increase the level by epidural supplementation. And US guided blocks are better than using nerve stimulator to locate the nerves, because this nerve stimulator current will again interfere with the pacemaker. So better go for US guided blocks. And what measures you can take to avoid or minimize the electromechanical interference, especially with the diether. Any idea? If you supposing there is no bipolar available and the surgeon insists that he has to use only unipolar or monopolar diether, then what precautions you have to?
We should keep the bipolar away to 20 centimeter.
Bipolar is not available.
Unipolar.
Only unipolar is there. So how can you avoid this electromechanical interference?
The current supply between 20 centimeters.
Earth plate and the current. Okay. So bipolar is recommended, but earth plate for unipolar cartridge is placed well away from the pacemaker generator. And avoid using the cartridge within 15 centimeters from the pacemaker generator. Okay, that is 6 inches. So if it is an abdominal surgery, below the costal level, it will be more than 6 inches. If it is in the left pectoral region, it's a common region where the pulse generator will be implemented. So your right paramedian incision or right subcostal incision, it will be well 6-7 inches away from that. So you can still use the cartridge in that location. But very close to the pulse generator, avoid usage of the health artery. And pacemaker should be converted to asynchronous mode in these cases, definitely. And equipment for temporary patients to be kept ready all the time. To prevent intraoperative hypothermia, which may cause shivering, especially during regional anesthesia. So, if you are doing anesthesia under spinal with a pacemaker, make sure that the patient is kept warm by all measures and shivering is prevented. So, what are the challenges patients with pacemaker posted for emergency surgery? Already we have seen that emergency circumstances complicate care of the patient, and so there is because of inadequate time to preoperative assessment as well as communication with the cardiologist or the technician or technologist for pacemaker will be not there. So better understanding between the anesthesiology and surgical team is necessary. And procedure above the umbilicus are at greater risk. And with monopolar electric surgery is used. So always insist on usage of bipolar. And after magnet is applied, ECG reading and the intra-arterial catheter waveform available should be compared. And the expected response to magnet application should be in patient with both the pacemaker and ICD should be there. And when there is inadequate time for placement of transcutaneous spacing or defibrillator pads, ensure that continuous ECG and pulse oximetry plethysmography monitoring is there to show any arrhythmias or bradyarrhythmia. What are the post-op care to be exercised? Restore the implants or the program back to the original level, immediate post-operative period. And CIED interrogations be performed after emergency surgery. And in any patient with suspected malfunction of the pacemaker or ICD. And for patients with ICD who have function of anti-tachycardia function has been disabled, and any malfunction detected, monitor the patient continuously by both ECG and pulse oximetry, and keep the transcutaneous spacing pads in place even in the post-operative period, so that anytime there is a malfunction or the arrhythmia happening, you can convert them back to normal level. And for prevent post-operative shivering also, when that people interfere with that. So these are the things that you have to know about pacemaker and ICD. As I told you, that to be divided into two parts, knowing about the pacemaker, the coding and all those things. And the second part is about the management of a patient with pacemaker. Right. Any questions on that?
Sir.